Thank you. Thank you for having me there virtually.
Yeah, and welcome. We have like lots of students here. We have like around, for the undergraduate student, we have around 110 students, and we also have the postgraduate is around, I don't know, is there any postgraduate student here already joining us? If someone from the postgraduate already joining us, can you raise your hand or something? Ada yang dari S2 sudah masuk?
Ada, Bu.
Ada, Bu. Ya, sudah. Ada berapa mahasiswa yang master?
Ready, Bu.
Oke, ada berapa totalnya yang master?
Berapa ya, Bu? Satu. Tunggu dulu, hitungin dulu. Satu.
Waduh, lama ini nanti.
Sekitar 10-an lebih, Bu.
Okay, so it's going to be around 10 students from the postgraduate nursing. And now we still do all the lectures like this. It's online, using online platform, Tayo, because, you know, the situation still not permit us to do the offline meeting. But we actually mix for the clinical skills, like the, you know, like in the emergency nursing or medical surgical nursing, we do some of the clinical skills in the offline, so face-to-face or directly, because it's kind of really hard to do it online for learning skills. Yeah. Okay, so without further ado, I think I will let Dr. Tayo to start the lecture, and you can also make a short introduction about yourself or something. But yeah, time is yours, Dr. Tayo.
Thank you. Can I share?
Yes, sure. You can share your screen.
Yeah. Hello, everyone. Let me start by saying Selamat siang. Oh my God.
Selamat siang, dokter.
Selamat siang.
Nice meeting you virtually. Let me share my screen. Can you see my screen now?
Yes,
Yes.
I can see it, Miss.
Yes.
All right. So, like I was introduced, my name is Temitayo Odewusi. I am from Nigeria. And what do I need to tell you about me? Yeah, I'm a nurse. And after working for some time, I went for my midwifery. And then after midwifery, I did my public health nursing. And after that, I went for my degree, my master's, and then my PhD. So I've been a nurse for over, how long now? Like 25 years, thereabouts now. So I've worked in the clinical setting, I've worked in the community setting, I've worked in the university. So in the last 15 years, no, like the last year, 12, 15 years, lecturer in the university. So I started as a clinical instructor, and then I became a clinical coordinator, and then I moved to full lecturing before coming for my PhD. So that's the short story. So today we are looking at gender issues in global health, maternal, sexual, and reproductive health. Can you hear me clearly?
Yes.
Yes.
All right. Okay, so as I go on, please, if you have any question, feel free, just go to the chat box and put your questions there, or your comments on whatever you are not clear about or that you want to add to what I'm saying. Okay. So like I said, Selamat siang. Yeah. So what are the learning outcomes of this presentation? So at the end of this lecture, I expect that everyone should be able to assess the challenges.
Dosen siapa? Yang ngajar kami.
Yeah, I believe everyone should be able to assess the challenges facing maternal health, critically analyze gender issues that influence adolescent sexual and reproductive health, then discuss the gender issues on adolescent sexual and reproductive health, maternal health, and global health in general. And lastly, to formulate an action plan, because by the time we are getting towards the end of the presentation, I expect that everyone should be able to think, to reflect and think, and be able to come up with, okay, what do I think is the way forward after hearing all this? So to formulate action plan for addressing the gender issues in order to meet the adolescent sexual and reproductive health needs. So those are the learning outcomes. And by introduction, according to the world statistics, the largest numbers and highest rates of maternal death occur in sub-Saharan Africa and South Asia. It's really sad. I know Nigeria, I'm from Nigeria, like I told you, Nigeria has one of the highest maternal mortality rates in the world. As of this morning, when I checked, the maternal mortality rate in Nigeria is 917 deaths per 100,000 live births. That's scary. And you know, I also tried to look at Indonesia, and I saw that the maternal mortality rate in Indonesia is around 177 deaths. Not too bad, but at the same time, it's not good because we don't want any woman to die as a result of pregnancy or pregnancy-related causes. So there is global increase in maternal mortality and morbidity rates, especially of young people, which is an area that I really want to focus on today. And that has been my research interest for some time now. There has been global increase in maternal mortality and morbidity rates of young people as a result of their sexual and reproductive health. And here, let me just say that this is actually a major reason that prompted me into my PhD. My PhD focused on the sexual and contraceptive health needs of young people. How power, dynamics of power influence these decisions that young people make. And what prompted me into this study was, when I was going through some studies, I saw that the maternal mortality rate in Nigeria kept increasing and increasing. And I'm like, what is really the problem? And because I was in the university setting, young people, I have the opportunity, young people always come to me to discuss about issues relating to their sexual and reproductive health. And I'm like, what is going wrong? What is going on? Young people always have questions related to their sexual and reproductive health. And looking at the literature actually points to the fact that the high maternal mortality rate, especially in Nigeria, young people contribute up to 60 to 70% of the death. And to me, that is quite alarming. And so I decided to find out, what is it about young people? How do they make their decisions to have sex if they want to have it? What do they consider before they have sex? And then in the use of contraceptives, what are their considerations, whether to use it or not to use contraceptive? Then there is gross gender inequality, especially in sexual and reproductive health issues. Gross gender inequality, and we are going to see this as we go about the presentation, as I go about the presentation. And there is an urgent need to identify and solve adolescent sexual and reproductive health issues. And this urgent need involves examining the social determinants of health, which we are still going to see later on. Now, by definition, gender. I want to define some of the key terms that I will use during the presentation. Gender, according to the World Health Organization in 2013, is defined as the socially constructed roles, behaviors, activities, and attributes that a given society considers appropriate for men and women. That is, the different social roles that societies and families expect people to fulfill because they are male or female. I believe in Indonesia, there are gender roles for male and there are gender roles for females. The same thing in Nigeria. It's all over the world. There are gender roles that the society actually prescribe in, in a way whereby as a child is growing, these roles are gently ingrained in a child, and the child gets to see that, oh, okay. And of course, mothers and fathers will always say, this is what a boy should do. This is what a man should do. This is what a woman should do. And before you know it, the child starts to, to practice all these things consciously and unconsciously after some time. And then maternal health refers to the health of women during pregnancy, childbirth, and postpartum period, that is 6 weeks after delivery. Then another one is sexual health. Sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. And then reproductive health. Reproductive health addresses the reproductive processes, functions, and systems at all stages of life. So which means that reproductive health has to do with the fact that people should have, or individuals should have, responsible, satisfying, and safe sex life, that they have the capability to reproduce and the freedom to decide if they want to reproduce, when they want to reproduce, and how often they want to reproduce. And you can see how this is really related to what we have been talking about, especially concerning the young people. And now global health. This is an area of study or an area of research or an area of practice that places a priority on improving health, achieving equity in health for all people worldwide. You can see that I have some phrases and words underlined here, there. These are very important when you are discussing global health. You cannot talk about global health without talking about improvement in health. You cannot talk about global health without focusing on achieving equity in health. And global health, just like I said, it's global, it's for everyone, it's for all people worldwide. And it emphasizes transnational health issues. That is, the issues that are involved in global health, they are not just confined to a country, but they actually extend beyond borders, boundaries of countries. Even though when you are dealing with issues of global health, you deal with it nationally, but you have to think about the implication of people moving in and out of a country. Then determinant solutions, it involves many disciplines. It's not only nursing, it's not only medicine. It involves finances, it involves agriculture, it involves transportation, it involves other disciplines within and beyond the health sciences. And it's a synthesis of population-based prevention. Because when you're talking about public health, or global health, you're looking at controlling diseases such that diseases and infections within a country will not be transmitted or transported to another country. And a very good example of this now is the COVID-19 situation that we are all facing. You know, that is a disease or an infection that is of global health importance. Even though global health is focused on synthesizing population-based prevention, but it's always focused on an individual. You know, an individual, or an individual is the unit when you are talking about healthcare. Although global health places greater priority on prevention, it also embraces curative, rehabilitative, and other aspects of clinical medicine and the study of basic sciences. And you can see some similarities in what I've been saying with our understanding of the concept of nursing. Nursing is about prevention, it's about curative, it's about rehabilitative, it's about supporting that person to be able to go back to his lifestyle, or to be able to perform those functions that he used to perform before his or her illness, as much as the body his health can permit it. Now I want us to look at maternal health in low and middle income countries. We all know the ideal. maternal health, we know that when a woman, before pregnancy, during pregnancy, after delivery, during delivery and after delivery, you don't expect a woman to die. That is the ideal. And all this can be achieved only if good health care system, if there is good health care system, if there are personnel to work there, if there are equipment to work with, if there are medications, if there are, everything is okay, everything is provided and is made available in order to meet the needs of this pregnant woman. But where there is a problem, whether in accessing the health care or in terms of affordability of the health care, in terms of availability and all the stuffs like that, there will always be problems. And majority of the problems in healthcare system in the world today, they are in the low and middle income countries. And some of the factors that are responsible for these maternal health issues are low literacy levels. When women are not educated, it's a problem. And that's why it is said that when you educate a woman, you have educated a nation. Because the woman is not the only one that is going to be educated. She's going to transmit that knowledge to her. She will use it for herself. She will use it for her children. She will influence her husband. She will influence everyone in her household. And when they are all influenced, they will all keep influencing other people. So literacy level is a problem. Then also in some culture, it is believed that there is no need to train a woman. After all, no matter the education of the woman, she will always land in the kitchen to cook, and all these ideologies, all these cultural beliefs, cultural norms, they affect because when there is a family, when a family has such belief, they find it difficult to train their girl children, their female children, because they feel that after all, they will end up, the girls will end up in some men's home. So there is no need, educating them. Ignorance is another problem. I know there is a part in Nigeria that's the northern part of Nigeria. People believe that when you deliver a child as a woman, the first child, if you deliver the child unaided, it is viewed with pride. And so even people who have, ladies or women who already have problems, they have complications, and they cannot even deliver by themselves. And they have been told that you deliver this child by CS, they see it as weakness. It's like, oh my God, my mom delivered by herself, my grandmother delivered by herself. Why does it have to be me that cannot deliver by myself? And this ignorance is a big problem. And that's why you see many women also dying during pregnancy, during delivery. Then early marriage or child marriage, that's another issue. The young age at first birth. Of course, if women get married, or young girls, when they get married, forcefully anyway, by age 10, by age 12, they have their first children by 13, by 14, thereabout. Too young, even when the reproductive system have not been fully developed to do so, to actually carry a baby. Then high order birth with short birth intervals among young women. This one talks about the fact that these women, because they start giving birth early, while a young girl that starts to give birth from a 12 or 13, of course, she will have those children in quick succession with little or no gap in between those children. Then low contraceptive use. Many of them don't even know what contraceptives are. Those who use it, who know it, they don't know how to use it. They don't know what to use. And then some of them, because of the cultural influence, because of religious beliefs, because of gender issues, they are not making use of contraceptives. And then negative religious and cultural beliefs, whereby teenage girls are married to much older men. That's another problem. And all these are actually peculiar. Majority of these problems are peculiar to low and middle income countries. And the last one I have here is there are cultural norms that restricts women from seeking health-related assistance. I don't know, I don't really know deeply the culture in Indonesia, but I know that in most sub-Saharan African countries, most women, they would have to take permission from their husbands before they seek health care. They will have to, if the husband is not there, they will have to seek permission from their mother-in-law or sister-in-law or brother-in-law. So it's difficult for women to make decisions, even when they know that this is the right thing that I need to do, but they are unable to do it because they are incapacitated, kind of, especially financially. And that's why one of the interventions now globally is empower women, empower women, empower women with education, empower women with, jobs that they can do that can fetch them something, little money or money such that they'll be able to make health-related decisions without waiting on their husband or somebody else. Now, like I said I'm going to focus more. I'm going to really focus this presentation on young people, because that is really my research focus. That is my area. That's my passion. And why am I interested in young people? Because adolescents are, any country that has adolescents, they are the assets of that country. Because very soon the leaders, they will have to go either by age or by their government being taken over one way or the other. It's the young people that will eventually become, whatever we are doing, we need to remember that the young people are looking at us, and they will one day, they will get to the post where we think we are. And if we don't focus on their health, then it means we are not really planning for the health, for the future of our own future or the future of the country. For example, if the health of the young people is not really looked after, we might end up having leaders who are not so healthy, or some majority of them could have actually died and not really reaching the adulthood stage. Then there are great potential resources in young people that they only need to be supported, they need to be encouraged. And if we can do that, we know that they are really great assets for any country. So adolescent sexual and reproductive health, like I said, the sexual activities of young people, they're actually different. It's marked by gender, it's marked by region. For example, the sexual activities of young people in Indonesia is different from those of Nigeria, it's different from those in the UK here, it's different from those in America, in Germany and, other countries in the world. Like, more boys are sexually active in Latin America and in the Caribbean, whereas in other countries, it might not be like that, and all these differences, they are functions of the culture of the people, their geographical locations, their religious beliefs, and other things like that. So adolescents, they also experience limited or no access to sexual and reproductive health education and contraception. So it is not only women, the other time when I was talking about maternal health, it is not only pregnant women or women that have restricted or limited access. Adolescents also experience limited or no access, especially to sexual and reproductive health education and contraception, which we are still going to talk about later. Let me give some facts and statistics about adolescent health. Studies have shown that more than 1.1 million adolescents that are aged between 10 and 19 years, they died in 2016. That is over 3,000 every day. And this has actually increased. Then road traffic injuries and others, like other related injuries or other related causes like suicide, interpersonal violence, HIV, stroke, AIDS, and diarrheal disease are the leading causes of death among adolescents. And this especially has to do with male adolescents. Majority of the male adolescents, which I'm still going to talk about, when they are unable to meet up with their gender roles or the norms in the society, you see some of them, the next thing is they go into depression, and then they kill themselves. And this is actually on the increase, especially here in the UK. Interpersonal violence and all other diseases like that. And globally, there are 44 births per 1,000 to girls aged 15 to 19 years, per year. This shows, unintended pregnancies, which is very common among young people because they are not really prepared for that stage of life. Many of them nobody gets to talk to them about sex, about anything related to it. And when they get to that stage, as a result of hormonal functioning, they feel some things and they want to try out things. They hear things from their friends and they want to try it out. And when they try it out, that's when maybe they become pregnant. That's when they now start to get information, whether right or wrong. Unfortunately, they often get wrong information, and from there, it often lands them in negative consequences. So the leading cause of death for 15 to 19-year-old girls globally is complications from pregnancy and childbirth. So I think with all this, it can now make sense to you why we have high maternal mortality especially in some countries in the world. Majority of these deaths, they are not really from older women, but they are from young people. Okay, so now let's start to look at gender influence on sexual health. When we say gender refers to the characteristics of women, men, girls, and boys that are socially constructed. So gender here has to do with how the society constructs their understanding of the different characteristics between a boy and a girl, a man and a woman. So all this includes norms, that is the standards, the expectations, the behaviors and roles associated with being a woman or a man or a girl or a boy, as well as the relationship they have with each other. So gender is a social construct. Gender varies from society to society and it changes over time. While gender norms are social norms, like I said earlier, defining acceptable and appropriate actions for men and women in a given group or society, they are embedded in formal and informal institutions. So when you talk about gender norms, it's not only at home. In school, you see gender norms being played out in the way teachers interact with students. For example, in primary, secondary school, telling them, oh, you guys, kind of sweep the floor, girls, that's your responsibility. The boys will maybe carry the table, lift the table. These are gender norms. They are gender roles. Who says a girl cannot do that? Who says a boy cannot do the other thing? So all these are embedded in the institutions and they play a role in shaping men and women's access to resources and freedoms, thus affecting their voice, their power and sense of self. I said it at the beginning that when a child is born and these gender norms that the parents have also been brought up with and which they have grown to accept, they will also try to, transfer the same to their children. And you see young children growing up, getting to know that I am a girl. These are the things I should do. These are the things I should not do. And the boy too would think, oh, I am a boy. As a boy, that's why I don't know what operates in Indonesia. But around me here, and even in Africa, in the Western world, anywhere you see boys, no matter how small a boy is, at home, the boy will tell you, if the father is not around, the boy will tell you, oh, dad is not around. Now I'm the man of the house. Even as young as 5 years, he will tell you, as I'm the man of the house. Those are gender roles that have been ingrained in us. And that's why when you want to do some things, even as a female, the first thing that will come to your mind is, oh, I'm a female, I shouldn't do that. Oh, I shouldn't sit like this. I shouldn't dress like this. I shouldn't do this like this. All these are because of the gender influences and the gender roles that we have been exposed to. Now I want you to look at the next slide. I have two slides. Yeah, I have the slide of I have a map of Indonesia on one side, and I have the map of Nigeria on the other side. And the reason why I decided to do this is because I saw that looking through literature, there are some similarities in some of the things I want to discuss from now, especially regarding the gender influences, regarding the culture, regarding the religion, and all those other things which I'm going to talk about later on. So that's why I brought out this map, these two maps, to be able to see what I'm talking about. So I'm referring to, I'm going to discuss based on studies that have been done, especially in relation to these two countries. So when we are talking about gender influences, gender is a key aspect of human sexuality. It interacts with sex, but is different from sex, which refers to the difference. So you can say that, oh, that's why, you know, before when we write to say your sex is male or female, some people have because of this understanding, some people are beginning to change it to gender, male or female. But gender goes beyond that. Gender refers to the different biological and physiological characteristics of females, males, and intersex or transgender persons. So the relationship between gender and sexuality is actually influenced by three major factors. There are the societal factors, that is, the things you hear from the society, from the community where you are, about what you should do, what you should not do as a girl, as a boy. What are those things that are expected from you? For example, in most societies, girls are not, or females or girls are not allowed to go out at some points. For example, when it's getting dark, you don't expect to see a woman outside in some cultures. And nobody will tell you that. These things are ingrained and they are passed down from the community, from the society, from your interaction with the society. And then there are interpersonal factors, and this has to do with how an individual communicates with the person of the same gender as you or somebody of opposite gender. And this is where a person, or especially young people, will get to know that, oh, I think I am attracted to this gender, or, oh, I don't like being around this kind of gender, or when I'm with this gender, these are the things I like to talk about, or these are the things I don't like to talk about. I don't feel comfortable, I don't feel free to discuss with, for example, a girl. When a girl is amongst other girls, she feels free to talk about anything, especially based on the discussion, whatever they are discussing. Whereas if the same girl is in the midst of boys, the things that she would have said while she was with girls, she wouldn't have said such things while she's with boys. These are interpersonal factors. This has to do with how gender controls or guide our relationship with other people. And the last one are the personal factors. That is, an individual looking at him or herself. How do I perceive myself? Who do I think I am by my gender? And this personal factor is a major reason for people now saying, oh, even though I am born as a woman, as a girl, as a female, but I think the way I feel I am a man within me, or I feel like I am this or I am that. All this has to do with the relationship between gender and sexuality as perceived by personal factors. And because these things have been accepted in the society, before then gradually it's becoming a norm that people are getting to accept. Even though it might be different from some of the cultural beliefs, it might be different from some religious beliefs, but because we know that you have to respect people for who they are, for who they claim to be, then there's nothing you can do about it, especially in the Western world. There are times when you see a female, I've come across some people, There was a time I received a phone call from someone, and the person told me the name. Actually, from the voice, it was a man. From what he said, it was a man. But from the name, it was a female's name. And I was wondering, I was just thinking, oh, strange. So male also bear this name. And he said, oh, for your record, I am transgender. Which means that day he chose to be a female. At other days, it could be a male. You know, that those are the relationship between gender and sexuality, how individuals perceive their gender and how they are able to communicate it to other people around them. Now, let's look at gender inequality. You know, by looking at gender, gender is hierarchical and it produces inequality. You know, I told you at the beginning that you are either a male or a female. I mean, those are the original or the fundamental gender forms that we have, either a male or a female, before the other intersex, transgender, and other groups, you know, come in. And by looking at these two, we also know that a man or a male or a boy is not regarded the same way as a girl in most societies. And these are functions of the culture, called functions of patriarchal system, which I believe also operates in Indonesia, which is a male-dominated culture, where the male has all the say, the men, they have all the say, and the women are relegated to the background. So gender is hierarchical, really. And because it's hierarchical, that means somebody has to take the lead, the other one has to be in the background, and that leads to inequalities. And these inequalities, we can see it in different forms. For example, unequal access to resources. Up to now, even in the UK, men they are paid more than females, even when they are doing the same job. The fact that you are a man, you are paid more. I think the same thing operates in the US and some other Western countries. Even though people now are clamoring for gender equity and, you know, and to close the inequality gap, which some organizations have been trying to do. Actually, the gap has greatly reduced, but it's still not the same thing. Of course, power. When men know that they are in charge, if you know you are in charge in a situation, there is a kind of power that you have once you are in charge. So that also brings about inequality. And this is one of the reasons why we have sexual violence in relationship, or where you see the men always taking the lead, always taking the initiative in any relationship. And then we have healthcare. Healthcare, where there is gender inequality, there is unequal access to healthcare. In some culture, when children are sick at home, parents will prefer to take the male child to the hospital to receive treatment rather than the female child. I have seen that a lot, and I've read about that too. That happens a lot. There are times when some parents, you know, when they have babies, they'll prefer to get their boys immunized, to get all the basic immunizations for the boy, but for the girl, it doesn't really matter. Even in food, while serving food, serving food at home, they give boys more portion or more meat than the girls. All these are gender, you know, these are the inequalities that are produced as a result of the gender norms, and, you know, they are influenced by the gender. Education, I think I talked about that earlier. Discriminatory socio-cultural practices. For example, in some culture, when you are a woman, you can't talk when people are talking or elders are talking. Women don't talk. Some culture, they're like, whatever you are, no matter how good that idea is, the fact that you are a woman, it's either people shut you down or you won't even have access to even be allowed to talk. And decision making. I mean, because of gender inequality, you see women, oftentimes, women are raised to wait for other people to make decisions for them. For example, when you are growing up, your father will always make decisions for you and your mother. When you get married, it's the husband that will make decision. When you are in a relationship, it's the boyfriend that will make decision. You know, all these are as a result of gender inequality, right? So what are the influence of gender norms on girls and women? I've actually talked about some of these things, and I will just quickly run through the barriers as a result of gender norms on females, on girls and women. They are risk to their health and well-being, restrictions on mobility, which I talked about earlier, lack of access to decision-making power, lower literacy rates, discriminatory attitudes of communities and healthcare providers, and lack of training and awareness amongst healthcare providers and health systems of the specific health needs and challenges of women and girls. Let me talk about the discriminatory attitudes here. You know, I don't know what operates in Indonesia, but I know that in most health facilities, especially in the middle income and lower and middle income countries, when adolescent female go there, especially to the sexual health clinics or family health clinics, they are not welcome. They don't welcome them. They don't really attend to them, except if they say, oh, I am married. Then you see health workers, you know, attending to them. Whereas if an adolescent boy goes to buy condom or goes to the sexual health clinics for reproductive health services, people don't usually frown at them, even healthcare providers. They don't frown at boys compared to females. And these are discriminatory attitudes as a result of the gender norms. Then, because of these gender influences, women face or girls face unintended pregnancies. That is pregnancy that they don't plan for, because they are not empowered with the right information in making their decision. They are exposed to sexually transmitted infections, including HIV and AIDS, especially as a result of sexual violence brought about by, it could be as a result of sexual violence, it could be as a result of lack of information. Cervical cancer, malnutrition, lower vision, respiratory infection, malnutrition and elder abuse, among others, high levels of violence rooted in gender inequality and are at grave risk of all this. Then harmful practices like female genital mutilation, and children are forced early into marriage. Then physical and or sexual intimate partner violence or non-partner sexual violence. For females, for women who are married, many women, they go through sexual violence from their husbands as a result of gender influence, especially where the man has been groomed and raised to know that I am the head, I am in charge. You dare not say anything against me. You dare not question me. And in that situation, if the woman, maybe as a result of her education, as a result of her exposure, as a result of information that she has been empowered with, if she says anything, the husband, of course, as a result of the unequal, because with gender influence, there is also unequal power relation. It often leads to sexual violence. Now, I want to balance it by looking at the influence of gender inequality on men and boys too, because it also has, gender inequality also has influence on the men too. And it's harmful also to them, especially where there are rigid notions of masculinity. That is, these are the things a boy should do. These are the things men should do. A man has to provide for his family, even when the man has problems, maybe has ill health and is unable to work as he should. He will still have it at the back of his mind that, oh, I am the man, I am the husband, I should be in charge. Specific notions of masculinity may encourage boys and men to smoke. For example, when they feel I'm in charge, nobody dares question me. They see all their friends smoking, people smoking around them. And in some culture, smoking is actually seen as a manly thing to do. It's for men. If you don't smoke, you are not a real man. So some of them, they get involved, they engage in such habits as a result of that, not really because they are deriving any pleasure from it. Then some take sexual and other health risk. For example, young boys, especially, remember in my study, I interviewed young people, and when I asked them about some of the sexual risk, health risk they took, some of them told me that they had sex because their friends had it. And while discussing, when their friends were discussing about their sexual escapades, those of them who had no sex, they felt immature. They told me they felt immature. They felt unexposed while their friends were talking about their own experiences and the number of girls that they had dated, and they had ended the relationship to start another one. Then men often misuse alcohol as a result of gender inequality. If they are unable to meet up with their the gender responsibility, those gender roles, they take to alcohol. Then some don't even seek help or health care because it's ingrained in them that you are a man. You must know everything, you must be in charge. Even when their health is failing, when they can see that, oh, this is not going well, or the way I'm feeling is not normal, they will think that, oh, it is not manly for me to tell people that I am sick. It is not manly for me to go to the hospital and complain. Not because they don't know they have problem, but because they feel that it's going to affect their ego. It's going to affect the societal perception about them as men regarding their gender roles. Then perpetrating violence to themselves and others. Some, as a result of that, they could actually inflict injuries on themselves or kill themselves or even kill their wives and their children, all because of inability to meet up with the society prescribed roles. And then some end up with mental health issues. They end up either with psychosis or neuroses or depression or bipolar disease as a result of gender inequality. So influence of rigid gender norms on persons with diverse gender identities. Here, because that is the world that we are in, we cannot exclude people, the diverse gender identities. I'm talking about the LGBTQs, the lesbians, the gays, the bisexual, the transgender, the intersex, and all the queer. So all these people too, they are also affected by the rigid gender norms, especially the gender norms that majority of the people have, that you are either a man or a woman. You can't say that people are looking at you, you have breasts, and we know that you are a woman, developed breasts, and you are saying you are a man. And they often face violence from other people. They are stigmatized, they are discriminated against, especially in healthcare settings too. They are at a higher risk of HIV, mental health problems, and suicide. I remember I worked in a nursing home here in the UK, and one of the residents, this man had tattoos all over him, but he will tell you that, say, I am a man. He's a man, but he will tell you, I'm a woman. And when he's dressed, he will actually ask that, oh, can you please, I want you to powder my face. Can you please help me to apply lipstick? You know, and he had his earrings always on. You know, he always uses earring. I mean, all these things are it wasn't everybody that was comfortable about him. I mean, being obvious, I mean, it was obvious that, I mean, this guy was a man, but he said, no, I am a woman. He said, I am the wife. I have a husband. And of course, the husband too is another man, you know. So, and they are to higher risk of HIV and AIDS, because we know people, especially those who are, some of these people, especially male to male, because they always end up having anal sex. They have a lot of problems associated with this, which could actually include the risk of HIV, AIDS. They are exposed to mental health problems and to suicide, especially when they're unable to meet up with the gender roles, whether of the one that they are born with or the one that they have actually adopted for themselves. So looking through the studies on adolescent sexual and reproductive health, we can see that gender norms and beliefs have significant implications for both girls and boys. And these are the 5 major things that often come out from the studies that have been done. There is this hegemonic truth, that is the predominant truth, that girls are vulnerable while boys are strong. So where you see a boy that is not as strong as the society expects, it becomes a problem. Where you see girls that are, even though girls are expected to be vulnerable, but they are trying to speak up and say, no, this is wrong, I cannot take this, then there is a problem. Then pubertal girls are the embodiment of sex and sexuality. That is, when people see young girls that are just beginning to bud, the breasts are just beginning to develop, the shape, their shapes are just beginning to come out like a young lady, all people see in them is about sex and their sexuality, and not anything, not about the intelligence, not about what they have in them, but it's all about their body, their shape, and sex. And then another thing that often comes up is that ladies should cover up and should not go out. Cover up, do not go out. Even when the reasons for covering up are not going out, when those reasons are not given to them. And then girls are believed to know, they are brought up to believe that boys are trouble. Don't get close to a boy, you will get pregnant. Don't get too near to a boy, you will do this. So they see boys. So when they are growing up, girls are raised to believe that boys are trouble. Then both boys and girls, they are aware of gender non-conforming peers. So because of the way they have been brought up, when a girl sees another girl that is not vulnerable, that is trying to speak and behave like a boy, they're like, this is not so normal. You are not a girl. As a girl, or a girl that says, oh, I like that guy, I want to go and tell him that I love him. Oh, that's not girlish. A girl should wait to be approached, not that you go to a boy to be approached. All these are gender-based issues. So the challenges on the parents and family, because most times parents, especially the family, especially parents, they don't really give young people the expected or the required information regarding their sexual and reproductive health. Then the society too has a culture that the culture, gender norms, values, and patriarchy system. All this influence the young people's sexual and reproductive health. And then religion, that is another one. A religion that oftentimes, especially Islamic religion, Christian religion, those two major religions, they actually create they create an inhibiting environment for adolescent and reproductive health. Because those equality, women and whatever base them, women should at the background, don't even support, they don't adolescent sexual and reproductive health. And one thing about this, that's my own opinion, if we take this religion without looking at the context of the things there, the culture of the people there, because the things that happen there with some of the culture, we cannot actually compare with our culture now. And then I said gender, all this, they bring about gender inequality, and then health service provider. And here I want to actually focus on nurses. Nurses are not doing well at all regarding adolescent sexual and reproductive health globally. In the Western country, there are a bit of improvement. Nurses still, even though with reservations, they still assist young people. But in African countries, in Asian countries, nurses are not helpful at all when it comes to the sexual and reproductive health of young people. many young people are not supported because of the nurses' personal beliefs, their personal religious beliefs, cultural beliefs, biases, attitudes against it. And because of that, they transfer that to the young people and they don't support them the way they should. They don't create the enabling, safe and supportive environment for young people regarding their sexual and reproductive health. And then mass media, young people get a lot of information, and we all know we are in information age. There's nothing you need at your fingertip, you just get it. Just need to go online and you get the information. The only thing is the ability to be able to sieve which information is right, which information is wrong. And then government in the Western world, they see the sexual and reproductive health of their people, especially young people, as a priority. So they start to teach them from a very young age, even though it has its own pros and cons too. But in African countries, in Asian, sub-Saharan African and Asian countries, it's a problem. There is lack of political will from the government, and the policies, they don't even create that enabling environment for young people for their sexual and reproductive health. Well, now I want to talk about the existing interventions. The two major interventions that have been used and are still in use comprehensive sexuality education and the youth-friendly adolescent sexual and reproductive health services. Comprehensive sexuality education has to do with inculcating sex education in the curriculum in schools, whether it's primary level, secondary level, or tertiary level. But we can see that this is also, it has faced a lot of bottlenecks, especially in some countries, countries that have strong religious and cultural beliefs. I remember that when this sexuality education started in Nigeria, the Parent-Teachers Forum kicked against it. The parents, especially, they kicked against it that the teachers were trying to teach their children immorality. So it's dragged on, and this parents, it wasn't as if parents were giving their children sex education, no, but they don't want them to know. So the government now devised a means of solving that problem. And in Nigeria, what they have in the curriculum now is family life and HIV education, because it happened during the time when HIV just came. I mean, everybody saw it as, oh, it was a big problem. And it was well accepted, everything and anything to stop HIV. So that was the method that the government used. But even at that, they call it FLHE, Family Life and HIV Education. Even at that, when I did a study sometimes and I interacted with teachers who were teaching this subject, and I still see that the teachers actually told me that they teach the part of that curriculum that they are comfortable to teach. And I asked, like what? They said anything related to sex, to contraceptives, they leave them out. Or parts of the body, they leave them out. And all these, they have implications on the information that the young people receive. And then youth-friendly adolescent sexual and reproductive health services. This is not, in the Western world, you have it all around. Young people can go there and discuss with nurses, with healthcare providers about their sexual and reproductive health needs. But it is not evenly distributed, especially in the low and middle income countries, because of those gender biases, because of these cultural issues, because of religious beliefs. So what is the way forward? Adolescent basic needs and rights need to be met within an enabling environment for them to survive. Young people need to survive, they need to thrive, and they need to develop their full transformative potential. And then the definition of health and well-being needs to be universal and holistic, and the response should be multidimensional. as you have seen from what I've been talking about, it involves that young person, the individual, it involves the friends, the parents, the family, the society, the institution, the school, the government. It's a multidimensional issue. And then it should meet the basic needs and rights of adolescents. That is, their ability to collaborate effectively through functional structures at all levels. Young people should not feel because I'm a young person, because I'm a girl, because I'm a boy, there is a place I cannot go to, there is somebody I cannot talk to, I cannot, when I have a need, I cannot, go out to people and trust them enough to be able to help me to meet my needs. Government with their multi-sectoral partners, they need to set national realistic yet sufficiently ambitious outcome. Most government don't pump money. Let me put it that way. They don't set money aside for adolescent sexual and reproductive health because they don't see it as a problem. There's a need to advocate for countries to develop and enforce supportive legislation and policy frameworks. I remember, let me use Nigeria as a case study. Here, we have so many policies and frameworks related to adolescent sexual and reproductive health. Beautiful policies, but not effective because of so many reasons. And one thing about government is, especially those who have a bit of commitment, they are not really interested. Until I remember I had a presentation one day about this issue, and there were government functionaries, and the way I started, I was like, imagine, governor, imagine your daughter was raped. I mean, the man, immediately I said it, he quickly sat up on his chair. When it doesn't affect them, they don't see it as a problem. And that is a major problem with people in power. Strengthen implementation research to understand why different approaches do work or do not work in different settings and for different adolescents. There are different groups of adolescents. For example, I looked at in-school adolescents and out-of-school adolescents, and they were in different settings, which I had to go and look for to be able to interview them to get the information I needed for my thesis. So we need to really go out for these young people and find out what their problems are in order to be able to meet their sexual and reproductive health needs. The way forward, the roles of nurses. I don't know in Indonesia, but I know in the Western world, in the UK here, in Africa, and in the US, nursing curricula does not prepare nurses well to deal with sexual and reproductive health issues. I stand to be corrected regarding Indonesia, but that is as far as I know. The curricula of schools of nursing, department of nursing, you only have us mentioning sexual health and reproductive health, maybe a lecture or two, but not adequately preparing nurses to deal with, how do you deal with a young adolescent with sexual and reproductive health issues? How do you deal with a person, a prepubertal boy and girl? What information do you have to give them as sex education or as sex information? Then when they are pregnant or when they need contraceptives, how do you attend to them without allowing your own personal biases, your culture, your religion to block whatever you want to do or to overshadow you in giving your care? Because it is still part of giving care to our clients. They are not our patients, they are our clients. So the practice also must reflect it. And then nursing research. And that's another reason why I decided to do my PhD in that area. I saw that there are very few sexual health nurse researchers. There are very few, because what really alerted me was when I was about to do my PhD viva, and we started, my supervisors and I, we started looking for a nurse to be my external examiner. And they discovered that there were not so many nurses. In fact, in Nigeria, I can't even say there is anyone. As big as Nigeria, I can't say there is one sexual health nurse researcher. And that is an area that is important. Don't forget, as human beings, we are sexual beings. There is no way we will not deal with the sexuality of people, even when we are caring for them with hypertension, with whether we are giving critical care or whatever aspect of preventive, whatever aspect of nursing, we will still deal with the sexual issues. of people. And we need to collaborate. It's very important. We need to know what's going on here, what's going on in another place, and how can we harness our ideas, how can we work together and see how we can transfer information or intervention and make it appropriate for the setting. So nurses have a lot to do. And then in giving our health information, it's neutral. That is, treat don't information peculiarity must be gender transformative. That is, the goal of empowering girls is to know and assert their rights. And the boys is to respect the equal rights of women without coercion, violence, and to clarify and fulfill their responsibilities. And that is why when we are raising children these days, what I tell people, and that's how I raise my own son, is when you have a friend, no matter what you want to do, no matter how good you think it is, if that person says no, if he says no, respect the no for no. And that is a way to make them gender transformative and not to think that I am a boy, what I say must be the law and that is how it should be. No, no, you have to respect the girls for who they are. And even your boys, your friends that are boys, respect them. Know that you have equal rights. And then girls should be empowered to know and assert their rights. God are the days when they think that they are just vulnerable. And so the global strategy for maternal and adolescent health for 2016 to 2030, according to the World Health Organization, using different platforms, Sustainable Development Goals, the HAHA method, the Leave No One Behind, and they have different packages of programs they are doing, is for young people and for women in their reproductive years to survive, to thrive, and transform. That is, survive, end preventable death, maternal mortality rate, neonatal mortality rate, 6-born death, under 5 mortality. All these things are preventable. These deaths are preventable if only we can do the needful. Then they need to thrive, ensure their health and well-being. Then transform, expand an enabling environment, give them a safe environment, give young people required correct information. And without be saying, oh, my religion, give them information so that when they get to that point when they want to have sex, they won't come to look for you. Of course, nobody does that. But at that point, the information you have given them, which is correct, they can now say, okay, do I want to do it? Knowing fully whether if I do it, I can get pregnant. If I go for abortion, I'll die. They already have this information at their fingertips. Or I could get infected, or I could do this, and then they have this information rather than getting into it and getting stuck. And all this should leave no one behind. Nobody should be left behind. And so, in conclusion, for us to have an effective program for maternal, especially adolescent sexual and reproductive health, if you look at this slide, you have to involve the adolescents, male and female. It's gone are the days when adults make decisions for them. Listen to them and then work together and come up with a solution. Work with community, including family members. These are stakeholders. Use materials designed for or by and for adolescents. Don't just use materials designed for them. Use materials that are designed by and for adolescents. Make accessible as identified by make services accessible as identified by adolescents. I remember there was a study where adolescents said, we don't want youth-friendly clinics to be in the hospital setting. Let it just be somewhere in the community where we can have a recreation center. And of course, we can check our HIV status. We can go for contraceptive services and all the stuff without necessarily being in the hospital setting. let the services be accessible to them. Incorporate monitoring and evaluation to know how effective those services and materials have been. Then identify target group, analyze assets and needs. For example, now studies these days are showing that adolescents that are out of school, they have been neglected. Adolescents between the ages of 10 to 14, they have been neglected in studies. The focus has always been on 15 to 19 years. The 10 to 14, they have been neglected. And they discovered that if problems that are identified now, if they are nipped at the bud while they were younger, many of them, it would have been easy to correct those wrong gender norms, and then it would have been easy to intervene early. So that brings me to the end of the presentation. And I will say, terima kasih banyak. I hope I got it.
Yeah, that's perfect, Tayo.
Thank you for having me. So now let me take your questions.
Okay, thank you very much, Tayo.
I can stop sharing my slide. Yeah. Right.
That was a really, really interesting presentation and lecture. Actually, we can really relate to what you were talking about, because in Indonesia, we are also still have like really high maternal mortality death. We are still above 300 number now, so that's still really high. And then in Indonesia, actually, we also have gone through several phases of, you know, feminism, when in the past, like, women considered to be only the companion of the husband, and they have 3 main roles in the kitchen, in the bedroom, and so they don't have like, you know, although it has changed, like it has been changing since the Reformation era in 1998, but actually it's still like controversial, and still many people believe that, okay, women should be at home or something like that. So it's still like really interesting discussion about gender, and I think it should open up our, like, you know, perspective, and it's gonna, like, actually gender also like really affect, yeah, the healthcare utilities, and yeah, that's really bad. And then actually I'm really surprised with your sentence that you mentioned, that actually there is not enough nurses that, like, you know, working towards like the sexual adolescent sexual health, and actually we really need that, especially in this era. So I think that's, wow, that's we need more of the people, or more people that do the research in that area. And also, like, especially because, like, yeah, in Indonesia we are also like a really strong patriarchal culture, so yeah, it's all still happening, so we can really relate here. Yeah. Okay, so we come to the discussion. Is there any question from the student who want to ask directly to Tayo here? Oh, actually we have the question here on the chat room. The first one is from Dianita. So Dianita actually is one of the lecturers as well in our school. And yeah, she's asking about how actually nurses could take part on local and global action to address gender inequality, especially its relation to obtain health services and to build power in order to advocate themselves. Would you like to answer the first question first?
Okay. Yeah, thank you for that question. How can nurses take part in local and global action to address gender inequality, especially its relation to obtain health services and to build power in order to advocate themselves? I think, especially if you're a nurse and you are in the academic environment, I think it's if you're interested, it's your responsibility to carry out studies and read about studies, especially regarding where you are. Because, like, when I started, I talked about the fact that there are different culture, there are different, you know, we are from different environments, we all have our different culture, we all have our different gender roles that have been ingrained in us. So we first need to understand the culture of the people where we are by carrying out the study to know what operates. And then we need to talk to young people. You know, in fact, maybe I should say that the first thing is, as nurses, we need to work on ourselves. What are my biases against adolescent sexual, or sexual and reproductive health? Do I have personal biases? Because if you have it, there is a need to put it aside if you really want to do this. So, this is not a time to, to bring about your personal biases. You are coming here to help, to assist, to support some people. So this is not a time where you say, oh, my culture forbids it. Oh, my religion does not permit me to say some words or to do some things. It's not about you here. You are helping some people. And that is one thing that I think nurses really, especially nurses in practice, they really need to look for a way of sorting out their personal biases regarding sexual and reproductive health. And then from the academic environment, we need to carry out studies. We need evidence-based information. And the findings from those studies, there are things that we can now work on. And then we can collaborate from other people. How have you been doing it? What are your experiences? These are my experiences. How were you able to do this? How were you able to solve these problems? And then that will also help us. For us to have an input globally, we need to start acting locally. It is what you have done locally that you can bring up, and then all this, when I bring up mine, you bring up yours, everyone, from different parts, then they become global issues that, of global solutions to the problem. But we can't solve global problem without acting locally. I hope I answered that question.
Yeah, I think that's right. Yeah, we need to start from our small circle, and then we can bring up this issue into global arena. I think, because I think about this gender issue, it's also really complicated, and regarding like the high maternal mortality in Indonesia also, it's like really complicated. It's not only about like the woman lack of education, but also the mix of the access also not adequate, because as you know, access to healthcare services, because as you know, Indonesia has country, and sometimes people who live like in the rural area, they need to go to the nearest healthcare facilities like around 4 hours by car or something like that. So sometimes it's just like really hard for the people to get to the, and also mix with the cultural norms, with the religious belief. And then sometimes also you talk about the personal bias from the nurses that providing the healthcare, and it's still happening as well. Sometimes we still bring our biases, and then we tend to judge like the the patient. So that's really
Actually, I have worked as a family planning nurse, provider, and I actually remember that I had my personal biases, and I used it against young people. Then, because I wasn't informed at that time, I remember I just newly graduated as a midwife, and I was working in a family planning section. And whenever young people came, I'm like, how old are you? What are you doing here? And of course it scares them. Anytime you say it, they run away. I remember one of my colleagues there said to one of the young people, did you tell your mommy you were coming here? And the girl felt so ashamed of herself. Exactly. She never returned. These are our biases. And of course, we can't blame ourselves too. We are humans.
Yeah.
We are also products of our gender norms, of our culture, of our environment. We have socialized with all this. So we are also part of it. But we need to know that we can't help the situation. And of course, I don't know whether that applies to Indonesia. One thing that nurses don't realize, which I often see, is that doctors use nurses to collect data for their study. Why nurses sit down and don't see the need to carry out studies? You get to some clinics, you see nurses taking, they're taking the name, your blood pressure, all these are your blood pressure, your weight, your height, your BMI, and everything. Doctors use all this for their own research. Whereas we will just, and unfortunately, they won't even acknowledge us because we see it as a routine work to do. Whereas we have this information at our fingertips. We can easily collect this information. And that's why it's also, it's also important for nurses, lecturers in academics to collaborate with nurses in practice area. You get a lot of information from people working in practice area, and then we can work together in order to, to provide or to design intervention that are evidence-based for our community.
Exactly. So the collaboration, like, yeah, the education and the practice, because sometimes there is a gap. We in the academics not really understand what's really going on in the field. So yeah, I agree. Okay, let's continue to the next question. So from Ainun, she want to ask, what should we do and what strategies should be implemented as a community nurse to provide health education on sexual or reproductive health to youth or adult community groups? Sorry, Taya, you are mute. We cannot hear you. Okay,
sorry.
Yeah.
Sorry about that. I said, I'm just reading the question again. What should we do and what strategies should be implemented as a community nurse to provide health education on sexual reproductive youth? Well, there are different things that can be done, especially as a community health nurse. For a community nurse, you need to find out, do you have, of course, you will have adolescents coming to, that are in the community. Do they come to the health facility? You need to know, do they come to the health facility? If they come to the health facility, what do they come there to do? And then from there, you can start interacting with maybe one or two to find out, oh, why do you always come here? Or why is it that you, or why is it that, why do you always come here if they are coming? If they don't come, why is it that we don't see many young people coming to the health facility? And then why is it that we don't see young people coming for sexual and reproductive health services? Then depending on what you also have available for them. As a community health nurse, you don't have to wait until they come to the hospital. Even as nurses generally, we can go to schools and talk to them. We can go and talk to young people about, sexual education involves menstrual hygiene. It involves care of your body before puberty, signs of puberty, what to do depending on the culture, depending on the availability, resources that are available in the community. These are sex education issues that you can talk to young people about. And one thing about sex education is, the moment you are able to do all these things consistently, young people will learn to trust you. And when they develop, once they start to build that trust in you, when it now gets to issue of, sex and contraceptive use, then it will not really, because you already formed a kind of relationship with them, then they see you as somebody that they can trust. And of course, when you are dealing with young people, confidentiality is very important. When young people talk to you, when a young person talks to you, and you say whatever the person has told you elsewhere, you will never see that young person again. That's one thing about them. They are so particular about privacy and confidentiality. And once you can maintain that and you can build that, see, one thing I've seen all over the world from studies is that, parents should be the first sex educator for their children, but most parents are not. And most parents are not, some not because they don't want to do it, but because they were not given. What you don't have, you can't give. And this is where nurses come in. Because whether parents or children or adults, they will always come in contact with nurses. And this is an avenue for us to really give them information and let them know, these, without condemning whatever they are doing, but just exposing them to that right information that they need. So you can do it as a community nurse. You can actually do it in your health facility. You can do it in your religious setting, in the mosque, in the church. You can have health forum and just give them basic information. The most important thing is whatever information you have to give, don't forget, must be gender neutral. It must be gender sensitive. and it must be gender transformative. And that's all you need. And before you know it, by the time you do it once, twice, 3 times, you will see them coming one by one to talk to you privately, to tell you about their issues. And one thing also about young people is when they come to talk to you, if they tell you, I don't want my mom to know, please don't let their mom know. And that is why you are a nurse. That's why you have been trained to do it, so that you will give them the right information. Because some of them, they don't just trust their parents when it comes to sexual and reproductive health. And let me say, it's kind of normal at a stage in life. You don't trust them because they always want the ideal. The ideal. It's like the parents are often like, you have to do this. You don't have sex before marriage. You don't do this before this. Forgetting that they were also adolescents at one point or the other in their lives, and without actually giving the right information. And of course, the society that we grew up as parents is not the same society our children are growing up. We didn't have access to so much of information. Now young people, they have access to any kind of information. And of course, when they watch the TV, everything they see there is sexualized. And music they listen to is all about sex. Everything around them is all about sex. Yet nobody is talking about sex today. So community nurse can really, really help. It can really, really do a lot in changing this. But it will have to start from giving right information to them. And then in the community setting, if you have access to, when it comes to all this family planning stuff or sexual and reproductive health, there are some free services, free products that they give. If you have access to this, then you can also help these young people and give them, if they need it. Then you can just have to look at, okay, what is the policy around here? How can we work around things? How can you advocate for them and then make things available for their use? Yeah.
Yeah, exactly. Because I think it's kind of like a culture as well here. Parents to talk about sex to their kids is kind of taboo, and it's like, I just don't know what to talk about with my kids. So the kids usually, yes, so they usually will search information from the internet. That's their resource.
But you know what? The thing is, and one thing I found out from my studies is that it's not, parents see it as taboo, but it's not really a taboo. For example, when a child is growing up, maybe when people always ask me, when is the best time to start sex education? I always respond that the best time to start sex education at home is as soon as your child can talk. I know it might be strange, but the thing is, you need to give age-appropriate information to that child. For example, if the child, a child that is just talking and say, this is my eyes, this is my nose, this is my mouth, this is, in some culture, when it gets to breast, they have a name for it. When it gets to vagina, they have a name for it. Why do you have to give a special name to it? Tell the child the real name without lowering your voice, without saying it behind closed doors, don't make anything special out of it. Let the child see that the way my eyes is, that's the way my breast is, that's the way my legs are, that's the way my vagina is, that's the way penis is. Let them grow up to know that. So that by the time you say it separately or give them a special name or do something funny because you are not comfortable with it, the day the child finds out the real name, the child will never trust you again as a parent. Because the child will say, oh, mom lied to me, daddy lied to me. Why did they lie to me? What is so special about it that they lied? And then you are now bringing up unnecessary curiosity in the child. But if you had told the child, oh, this is this, it's just a part of your body. Take care of it, protect yourself, do this, that's it. Just like you said, protect your eye. Don't let anything come there. So protect this one. Don't let anybody touch it. Don't let anybody touch you. Just all those basic information, and that's all they need. And that is sex education, without talking about having sex. Right?
Yeah, that's true. Okay, so I think we don't have much time, so I'll read from the bottom, the last question. I think it's also like a really interesting question. So from Farha, yeah, she asked about that we found so many cases of child marriage that in Yogyakarta is the city where we live now, and actually this harm both girls and boys. And she wants to ask, how is the child marriage prevention program implemented in your country? And how to assist a girl or a boy who is already married, especially in if they are still young, it's in terms of their health?
Okay. Well, you know, when I was doing the presentation, I mentioned the fact that the way forward is multidimensional. It's just one, not just about the adolescent alone, not the parents alone. It takes a lot of effort. In this kind of scenario that Fahab, you know, painted, for us to meet this problem, there needs to be a community awareness program. Because this is a community thing. I mean, child marriage is not just a family thing, it's a community thing. People need to know, the community needs to know, maybe through the religious organizations or community, any community-based organization. You can start from there. One thing about this issue of sexual and reproductive health is you have to be intentional about it. You must be intentional that, oh, I'm really passionate about this. This is what I don't like.
Hello.
Hello? Okay. That I don't like the way young girls are, you know, their health is being affected as a result of this. So you have to be intentional. You have to work with some people, create community awareness, advocate for young people. You know, when you let people know that the girls, the 10 to 12 years, this is how far they have developed. This is how far their reproductive system has developed. For some of them, at that stage, they have not even started their menstruation. And let them see how all this impact on their reproductive health. And of course, the likely consequences, for example, like vesicovaginal fistula, rectal vagina, all this, by the time you let them know, people start to think, oh, so this is it. Then a big thing here is government policy. If there are good policies, I mean, if the government sees it as a problem and they're able to kind of enact a law against it, for example, in Nigeria now, child marriage now is a law in Nigeria against it. Though some people still do it subtly, you know, in some culture, but there is a law against it. That anyone that is not 18 years should not be allowed to get married by any parent, except the person decides to do it, to get pregnant and get married, you know, on their own. So it's a law. So that's why I said it's a combined effort. The government, the healthcare provider, because it is the studies that healthcare workers do or the information you've received that you are going to feed the government and people in power with. That these are the things we are, you know, finding in our health facility. These are the problems that we see. And of course, you can talk with the young people and let them know these are the situations. Young people at times, they can actually speak in some situations if they are allowed to speak also. So it's a whole lot of problems, you know, I mean, a whole lot of intervention has to take place, but not just a single intervention. So in Nigeria, I know there is a law against it. And then there is a sensitization programs all around to inform people and to let them know the harmful effects of child marriage, especially on that girl, on the unborn child, and even on her health, future health. Yeah. So for a girl that is already married, then you need to find a way, like I said, sex education. Talk to the girl. Find out, is there any information, is she well informed about contraception? So that she can make up her mind when to have another pregnancy. That is when she's ready for it. And not that she'll just find out that she's pregnant while she has a 5 or 6 months old baby that she's still nursing. You know, all these they just need information. So for that girl, all you just need is to support her contraception, nutrition wise, what to eat, how to take care of herself, you know, and things to just do. Yeah.
Yeah, I think that's clear. In Indonesia, we also have the law actually. So the government just issued the latest regulation that the girls only can marry after 19 years old, and for the boys 21 years old. But yeah, you know, in the practice, in the community, the child marriage still happening, and sometimes they make up for the age. So when the girl is only 16 years old, and then they make up like, oh, actually she's like already 18 or 19, and in some part of Indonesia even it's happening like only 12 years old, 13 years old of little girl, they're marrying like the old man like 40 years old or above because of, you know, the economic situation of their parents and stuff. So I think we still can take one more question, yeah, before we run out of time. It's from Pak Dinasti Pudang. So he's asking about there is a phenomenon in Indonesia related to sexuality in adolescents. Adolescents engage in sexual activity outside of marriage, resulting in pregnancy outside of marriage. And usually the children who are born also experience many problems. As an example is stunting. So what do you think about the role of nurses in this phenomenon to prevent like the stunting and stuff?
And it also happens in Nigeria. You know, still, I will still refer to what I've said, that people just need information. You know, most of these things is because people are not well informed, and because these gender norms, the moment we are being raised with these gender norms, and you just see that before you make decisions about some things, you know, it's just as a result of those gender norms, gender roles that we have ingrained in us. Those are the things that often propel us to make a decision. But when people have information and you're able to process it and you're like, oh no, okay, so this has been happening because I have been doing this, so I need to stop this. So people need information to be able to know. I don't know. Sorry, who asked that question? I want to read that question to really have an understanding of it. You are muted.
The second from the bottom, Dinasti Pudang.
Okay. All right. I just want to read it related to sexuality. Yeah, when children are born into this kind of situation, you know, it's like children giving birth to children. And what it often does is that the cycle of poverty just continues like that. And so there is a risk, or there are risks to the parents of the children, especially the mother. Also, there are greater risk to the children. So this now has to do with, you know, nurses, like I said, nurses have a lot of role to play in this, giving them information. There are times when, because you know, some of these children, they end up becoming stunted. But before they get stunted, for example, if they are pregnant and they come to the clinic, you would have known that this will be the likely situation if care is not taken. But when they come, if they give them the adequate information, especially nutrition-wise, making use of locally available foodstuff to prepare food, nutritious food for the child. So that even though they are, of course, most of things like this happen to people who are not so rich. So even when they cannot afford expensive foods that are nutritious, they can still get the needed nutrients from the locally available foodstuff. And also cleanliness is also important here to teach them, because some of them, even where they are able to get little nutrients from whatever food they are able to eat, after a while, before you know it, the child will end up having diarrheal fever. And then the child will lose whatever nutrient again that the child has, worsening the situation. So these are things that we can do as nurses. Of course, we cannot keep giving everybody food from our post. It's not easy. All we can do is just to, you know, what I have seen in nowadays is that when you empower people with right information, it goes a long way in solving their problems. And of course, nurses as advocates of our clients, our patients, if you see any opportunity, because there are times where you have maybe the government or foreign aids, and they want to empower women, especially with small business that they can do to take care of themselves and their children. We can advocate for this kind of situation. You know, oh, we have a patient here sometimes, and she delivered, and this is it. And then they can empower the woman on what to do in order to care for our children. I remember that in public health nursing, this is something that we do a lot. We try to empower women, looking at what they can do. Do you have things that you can plant around your house, like vegetables, fruits, and other things that you can plant, so that you don't have to keep buying things, but you can just go behind. I don't know how good the weather is in Indonesia and then the soil there. But I know, like in Africa, we encourage women to plant vegetables around the house so that they can always go there. You don't need to buy. You can just go there, pluck whatever you need, prepare it, and, you know, give your children, so that at least they're able to take nutritious food from locally. You don't need to buy meat, but there are some things you can get locally and still prepare, and you still get the nutrients that are needed. But in all, the best thing is to avoid it, to stop that practice of child marriage. Because when you stop it, it will really go a long way, also helping nurses too. But in as much as we still have them amongst us, we need to look at the resources that are available, that are within our reach, and then use that to give them information. And there are times we actually need to demonstrate to some of these young girls how to prepare this food, because some of them don't even know how to prepare, especially making use of locally available food. So I don't remember when I was working at the public health setting, every week we do nutrition demonstration, where we call this young infant welfare clinic. We'll teach them how to prepare locally available food in a nutritious way for their babies.
Okay, I think that's answered that question really well. So since we already have the Azan Maghrib, it's a call for the prayer now here. I think we gonna end the lecture today, and thank you very much for the really interesting material and topic. And then what I can say is one of the vital role of the nurses in the community is become the source of the information by providing the correct information to the adolescent about their sexual and reproductive health, and also try to empower them to use the resources that around them, like for planting the vegetable or everything, to empower the woman without bringing our, like the personal bias. We should put aside the personal bias when we providing the information to the adolescents, without also judging them of what, like if they do something right or wrong. And also the most important thing is to keep like the confidentiality. That's also the most important thing. Even if we know their parents, we shouldn't tell that, oh, your kids come to me asking about this, so that's you could not never see the adolescent anymore. So before we close the session, do you have another take-home message for us all here?
All right.
Is there any take-home message?
Yeah, my take-home message is, I'll still repeat what I've said, that as nurses, let us try, just like Tantri just said, let us try to put away our biases, because young people will always say nurses are judgmental. Oh, they are always there to castigate you, to condemn you and this. Let us put all this aside. Our role is, of course, if a person comes to the hospital, if we have a patient that has acute renal failure, that needs renal or what do you call it now, dialysis, we will not say that, oh, you caused the problem for yourself and that's why you need it. No, we will have to do what the needful to resuscitate that person back to life. The same thing for these young people. They might have made mistakes, but that doesn't mean that we will keep castigating them. We should also remember, while we were in that age, the things we did, because we have all been adolescents at one point or the other in our lives. And when we can do this, we'll make life much easier. And I discovered nowadays that parents, they actually now want sex education for their children. At least when I collected my data, many parents approached me and they wanted me to come and give sex education to their children, because they said they have now seen it, that it's a problem. We need people to tell them. We don't know what to tell them as parents. So the world is changing, and we also need to change, especially positively, with the world in order to impact humanity in a very positive way. Thank you.
Thank you very much, Tayo. I think that's all for our today's lecture, and I hope this is not the last time, ya, Tayo, you will be our guest lecturer in our school. We're gonna invite you more in the future.
All right, thank you.
I think the students also really excited. Should we have like a photo together in the last session? So maybe everyone can open the camera a bit so we can have like a photo together. For the student here, can you open? Bisakah dibuka kameranya sebentar? Kita foto bersama. Yang masih menyimak, ayo kita buka kameranya sebentar, kita foto terlebih dahulu. Oke, not so many people here. Oke, kita foto ya. 1, 2, 3. Ya. Oke.
Thank
all.
you.
Yeah, stay safe and stay healthy. And yeah, we'll get to talk again.
Safe. Take care of yourselves. Yeah.
Yeah, thank you very much, everyone.
Yeah.
Bye.
Yeah.
Bye, thank you, Dr. Tayo.
Thank you for having me. Bye-bye.
Bye-bye. Terima kasih semuanya.
Terima kasih, Ibu.